Now let's get into the four major classifications of shock, the causes of shock. So the first one is hypovolemic. So our pathophysiology for hypovolemic shock is that we have decreased intravascular volume, significant decreased intravascular volume, decreased venous return, decreased filling of the heart, leading to decreased cardiac output. So you're probably thinking of a lot of different reasons why somebody would go into hypovolemic shock. There is a box in Chapter 54 that talks about the etiology, but we're looking at things like hemorrhaging, either internally or externally, major traumas, massive fluid shifts such as ascites or the loss of fluid outside of the body because of massive burns, or severe dehydration. So those can all be causes of hypovolemic shock, and our basic goal with that is to find out what the underlying problem is, correct it if possible, and restore the fluid volume. So there are various methods of fluid replacements, and depending on the type of fluid loss, there is a table in Chapter 54 as well. So we have our crystalloids, our volume expanders, normal saline or lactated Ringer's lactate. And just a little note about Ringer's lactate. The reason that we use that a lot in patients who have the potential of going into shock is that it has a buffer for the lactic acid that is produced when those cells switch to anaerobic metabolism and leading to metabolic acidosis. So lactated Ringer's or Ringer's lactate is a buffer for that low pH to bring it back up to normal. So that's why you'll see lactated Ringer's a lot in patients who are at risk for or are going into shock. Colloids that contain proteins by osmotic pressure pulling fluid back into the intravascular space. So albumin, dextran, hetastarch are all increased plasma volume by pulling fluid back into the intravascular space. And then obviously if a patient has a massive blood loss, we're going to give things like whole blood, packed red blood cells, fresh frozen plasma, platelets, that sort of thing. So hypovolemic shock is there's not enough blood to be pumped around the body. The next type is cardiogenic. Now with cardiogenic, we may have adequate blood volume, but the heart has failed as a pump. So cardiogenic is a failure of the pump to pump. So some of the causes of cardiogenic shock, a major cause of cardiogenic shock is having an MI, a massive MI that has damaged a significant amount of the myocardium. Dysrhythmias, severe congestive heart failure, pulmonary emboli, valvular damage, anything that puts such an intense workload on the heart that the heart begins to fail as a pump. So when you're looking at the clinically specific signs and symptoms for cardiogenic shock, think of somebody in really, really, really bad heart failure. So all of those signs and symptoms of right and left-sided heart failure are going to be present in that patient with cardiogenic shock. They're going to have increased central venous pressure because of fluid overload, JVD, pulmonary edema, peripheral edema, hepatomegaly, ascites. So all of these things can happen because of the fact that the heart cannot pump effectively. It cannot expand enough to accept the fluid that's coming back to it. And so the heart has failed as a pump. That is cardiogenic shock. The treatment is to correct the underlying problem. If they've had a massive MI, they may need to go have a CABG or go to the cardiac cath lab and have a PCTA. They may need to have their valves replaced. Or we will treat any dysrhythmias that are causing this cardiogenic shock. So finding out what that underlying problem is and correcting it so that the heart can go back to normal function. Some of the medications that we give for patients in cardiogenic shock, because we are looking to improve myocardial contractility, we are looking to increase their blood pressure by increasing vasoconstriction, and if our cardiogenic shock was caused by an MI, we need to improve the perfusion of the myocardium so we don't have any more myocardial damage, like we talked about back in our cardiovascular unit. So one of the medications that we give to improve myocardial contractility is dobutamine, not to be confused with dopamine. What dobutamine does is it helps to improve myocardial contractility. And one of the ways it helps the heart to pump better is to decrease systemic vascular resistance. So it relaxes peripheral blood vessels. Well, what happens when you relax your peripheral blood vessels? Your blood pressure goes down. We've already got a patient whose mean arterial pressure is low. It's below 60 because of their poor pump ability. So now we've got a situation where this med, it is helping to strengthen the heart, is also lowering the blood pressure, which we don't want to happen. So then we give a vasopressor, a medication that promotes vasoconstriction. An example of that is dopamine or norepinephrine. Those help to improve our blood pressure by constricting our peripheral blood vessels. But we don't want to constrict them too much because we have a very weak heart, and we don't want that heart to have to pump against that much afterload, that much resistance. So we're titrating the vasopressor, the dopamine, for example, to maintain an adequate blood pressure, but not too high that it can cause further damage to the heart. And then if we need to open up those coronary arteries to promote better perfusion of the myocardium in the case of an MI, we're going to give a nitrate intravenously. And then to enhance perfusion of the myocardium, we're going to give sodium nitroprusside, a vasodilator, which will help to improve perfusion of the myocardium. But what does a vasodilator do? The vasodilator will lower the blood pressure. So all three of these medications are going to have to be titrated very, very carefully using our arterial line, our pulmonary artery catheter, in order to make sure that we have adequate blood pressure, but not too high so that the heart has to work harder.